patient-generated data, but the end-user experience of patient-generated data. So if you thought you were someplace else, you want to stay here, because this is where the cool panel is. My name is Kelly Santomas. I am the Senior Director at Partners Connected Health. And one of the projects that we're working on is really integrating patient-generated health data into the medical record. And the thing that we really are trying to get right is, how do our end users experience that? How do we make it so that as we're building these tools, that it's actionable not only by the provider, but by the patient, and they have very different needs. So that's going to be the purpose of the panel this afternoon, is to really talk about the patient experience, the provider experience, and then also the companies that are building this technology. What's the feedback that they're getting, and then how are they going to sit there and sort of make adjustments, and what are they looking at into the future? So what I want to do is we'll introduce the panel first, so that you know who's here, and then we'll get started. So Steve, I'll start with you if you want to introduce yourself.
My name is Stephen Van. I'm the patient that had experience with patient-generated data that I collect on a daily basis. But I was also part of a study that helped change my view and my participation in my own health.
I'm Schiller. I'm the CEO at Validic. We connect patient-generated health data from digital health apps, wearables, and in-home medical devices into the healthcare system, standardize and normalize the data to a common ontology, and provide actionable insights into the clinical workflow for the purposes of care delivery, as well as wellness and prevention and research and discovery.
And I'm Goscila. I'm a nurse practitioner at PGHD and Revere, and I've been using one of the blood pressure monitors for about 2 years now with some of my patients involved in a research study.
So we do have a variety of opinions that we hope that we can share sort of our insights and what we're doing. So Steve, we're going to start with you. Why did you decide to move to a technology solution to manage your care?
It's a very good question, first of all. Kind of the why. Why did I do this? For me, I've been a diabetic for over 20 years, 20 plus years. With the chronic condition like that, I had tried several different methodologies, you might say, out there to change the condition of my diabetes. And for years, nothing helped lower my A1C, basically. I tried different diets, I tried many different things. I had an opportunity to be, as I said earlier, part of the study, but I really I looked for a solution because the current solutions weren't working. So the why was to try to find something that would change the outcome of my diabetes condition, because I was getting more medication. I was actually feeling worse every day, and I felt like I really needed to change, and I got the opportunity.
So in using the solution, what did you find? What was your experience when you finally found this piece of technology? How did it help you?
Another very good question.
We try.
But I mean, I say it's a good question because it really cuts to the chase of not only the why, but the what for me. A person with a chronic condition, one of the things I learned over time is with diabetes, you have it every second of every minute, of every hour, of every day, of every on and on and on for the rest of your life. You can't, there's no shot or pill that's going to change that, other than how you manage it. And the better you manage it, the better your condition, the better you're going to feel, and the better your daily life is going to be. This experience helped change that. Not only did it change my A1C level, which was my first goal, but it really got me closer to my health. I was able to look at data that was being collected that I really in the past wasn't able to see. wasn't able to see what the data meant. You get a blood sugar of 120 or 180 or 200. Well, what does that mean, and how did it get there, and what were the steps that got me into this position? I'm not a data genius. I'm just a person with a chronic condition that tracks my blood sugar. Through this process, my doctor and I were able to take a look at the data and to see behavior patterns that actually resonated with me, that made sense. I could look at the data and I could see my behavior. The better I looked at my data, the better I could look at my behavior in a way that I could change my behavior. And when I changed my behavior, I was able to change the outcomes. And those outcomes were a lower A1C. And I think even more so for me, it's understanding it, getting closer to it, and then behaving in a way that's different.
So you told an interesting story too when we had talked a while back, that to be specific as far as your popcorn addiction. So,
Yeah.
so just to give a concrete example for people, could you describe tell that story about how?
Yeah.
Because
This is my aha moment. So my kids had gone on to college, right? So my wife and I are home. For once, we had the family room by ourselves. We could watch what we wanted to. So every night we'd watch Netflix, right? We try to binge out for an hour, 2 hours a night. And what we did is we would have dinner first, and then we'd have a little light snack with the movie, just like everybody else does. What was happening during that time is that I was part of the study, and they were looking at all this data. They were looking at all the information, and I then met with my care providers, and they said, Steve, how your A1C is going down, but we're looking at something going on in the evening, about maybe between 7 and 10 p.m. And I said, well, wait a minute, we've had dinner, and I'm having a really healthy snack. And they said, well, what is it? I said, I have it every time. I said, well, what is it? I said, it's popcorn. Isn't that healthy? And they said, no, Steve, that's corn. No, that's not gonna help you, right? But for me, it was something that I had heard of and thought of. I wasn't going by the data, I was going by what I thought I knew. And I think that happens for a lot of us. And until we can understand the one-to-one relationship, and we can have the touch points. Between 7 and 9 p.m., my blood sugar goes up 50 points because I have a big bushel of popcorn. Then I started looking at everything that way. All those things that I thought in the past were very healthy, but really aren't. That kept my blood sugar down, but really didn't. And as I began to see that data differently, my doctor and I did have a different conversation.
Yeah, and Kelly, just to give a little more context here, so the Steve's story is phenomenal, and basically the high level that enabled this is that Steve was enrolled in a program, Validic had a good fortune to participate in, where data that were collected from his devices in the real world, so glucose, blood pressure, weight, nutrition, physical activity, was captured and delivered into the clinical workflow so that the clinical care team could actually view the data in the workflow and start to take meaningful action based on that. And that was really where the dialogue started to change.
Christina, so you talked a little bit about how you guys are integrating blood pressure. So with this, how is that impacting your workflow? Or are you able to integrate it into your workflow? Are you utilizing technology?
So how we got started with this is about 2 years ago, we started a primary care improvement process plan working with folks over at MIT. And so we have a doctoral student who's getting data for us on our specific patients. And then we're doing research on whether or not this will help their blood pressures by using technology like this. what our goal was is twofold, is for one, to help patients decrease their blood pressures, but secondly, we wanted to keep the patients out of the office. We wanted to be able to do this remotely and have touch points every 2 weeks where our nurses would actually contact the patients and relay the data and the messages to the provider. Then the provider makes a clinical decision, relays it back. The nurses are also involved in dietary, lifestyle changes and things like that. So it's trying to have the entire primary care team working on the patients as opposed to it always being the provider is the end user. We had it more the nurses were the end users. This also helps them work at their license, to the top of their license, which helps their workflows and it actually helps their work satisfaction. So how this has helped us is that it's taken a little bit of the workload off of the provider while also making sure that the patients are still well taken care of, and it's also increased our availability for providers. So now we have open spots, open session spots, where we didn't have them before. And so it really works into that whole notion of primary care moving towards, more a population management model and being able to increase the providers' panels without overwhelming them with all this other administrative work.
How's the feedback been from your patients?
So right now we have 30 patients involved in this study. They've been randomized. So there's about 12 patients who are using the equipment. There's been varying stages of satisfaction, let's say, or I think more understanding. So some patients aren't really understanding what we're trying to do. Other patients are right on it and they're interacting. They're patient gateway messaging us and I did this today. My blood pressure was high today. This is the reason why. Like they really trying to be interactive with us, which is great. And other patients, their use of it, they just haven't connected yet. They haven't caught on yet. But we're still working on them. But for the patients who have engaged, it's been really incredible. We've had some patients come off of blood pressure medications because they didn't realize that some of their health, their eating habits or their exercise habits were really, or their stress levels were really impacting their blood pressure. Anxiety was a huge one. We had one patient who, she was so anxious that she didn't want to take her blood pressure. But when she took her blood pressure and realized her anxiety was causing her blood pressure to be high, it came down, which was really kind of great. And we had put her on 5 milligrams of lisinopril. Super happy, she's not as anxious, and now she's just chugging along. She's doing it every 2 weeks. So it's been really nice. It's been definitely a learning curve when it comes to providers backing off and giving some of that patient care to other team members. But I think in the long run, it's gonna improve everyone's work satisfaction as well as patient satisfaction because they're getting more touches. They're getting more personalized touches.
So, Drew, for you, I'm a little curious as you're listening to the stories, but I want to step back a little bit. Why did you create what you created? What was sort of the impetus behind it?
Yeah, so I'll talk about Validic in general and then talk maybe a little bit more specifically about some of the work. And by the way, I love the story that you just told because you're trying things in a fast, iterative manner, in a way that's engaging team members, and I think that's a phenomenal approach, so kudos to that. So I would love to say that I woke up one day and was like, hey, you know what the world is missing? It's the ability to bring data in from all these devices. But my co-founder and I, we started the company in 2010, and really we were really focused on more of the population health engagement initiatives. And at some point we realized we needed to build more programming options than what we were able to do at the time. And this was back in 2012, and we thought, well, we can't build a better step tracker than Fitbit, or better running app than Runkeeper, or nutrition app than MyFitnessPal, and all this. And so, after like knocking our heads against the wall for a couple weeks on this problem, we realized, wait a minute, why don't we just integrate with them? So that was kind of our big moment, and we started going out to the space and saying, hey, look, we have this engagement platform that integrates all these apps and devices, and everyone said, we all already do engagement, but nobody has this data. Can we please access that? So we launched Validic in April 2013, and we've been extremely fortunate since then. And our mission at Validic is to improve the quality of human life by building technology that makes personal data actionable. And it's that personal data actionable part that's really important, and where we can start to really take a stand as a company, because it's one thing to get the data, right? It's one thing to bring the data into the healthcare system in a meaningful way. It's another thing to actually make the information actionable in a way that clinical staff members can actually use the data. And so one of the things that we've done around that, we launched at the beginning of the year a product that allows us to effectively bring the data into the clinical workflow with care programs that clinical staff teams can actually design and structure on their own. It's kind of like WordPress for care management, right? Rather than picking up the phone and calling patients and trying to figure out what their readings are, expecting them to come into a clinic, we enable programs like yours, and the one Steve was discussing, where that it just comes in automatically, and clinical staff members are alerted when there's clinical intervention points that they need to take action on, rather than seeing all of the data. The other thing that we've really been focused on is how do we actually start to leverage the fact that Validic has a lot of information out there to be able to start to provide some analysis of the data, so that we're able to provide some predictions. So we can tell things, for example, like when someone's going to stop using a device. We can tell things like the fact that we can predict blood glucose values, so we can advance the accuracy of the meter itself. Things like this, where we can actually start to deliver actionable intelligence about data in our system, again, in the clinical workflow for people to actually take care. So really providing that actionability.
And I think that's the big piece, right? Is just data for data's sake doesn't really do anybody any good. And then then we'll hear from practices like Christine's to sit there and say, okay, you've given me a bunch of stuff, but I can't see it, and I can't do anything.
Yeah, and can I just say one thing you said, Christine, which is phenomenal to hear, because one concern we hear sometimes is, and this is not Validic, this is digital health in general, is a concern that, well, does digital health start to make doctors obsolete, right? Or could it replace doctors? And that's something that I personally hear sometimes. And I'll say one of the things I love about what you said is that you're actually freeing up your doctor's time to actually practice medicine by allowing them to leverage their care team, which, like, how amazing would that be if doctors could just be doctors and really take care of the intense patients, rather than just trying to kind of churn through.
Right. And so what we're looking at with the MIT data that we've collected is we've actually taken a subset of patients and looked at how many times they entered the clinic on a yearly basis and what those visits were for. And so we did all of this pre-data crunching, and it turned out that patients were coming to see their doctors more for follow-ups of blood pressure checks and diabetes care, and not an awful lot changed after that visit. So medications weren't changed, blood pressure medications weren't changed, and so really what was the value of that visit? We don't know whether there was another issue or whatever happened, but the data showed us that those visits really weren't very valuable. And I know in my clinic, we have a backlog of patients on waiting lists trying to get in, also patients waiting a year for physical exam, and so that's, patient availability is one of those big things that primary care is always looking at. And so freeing up those follow-up appointments is what we're really trying, that's one of our major goals. And so then the doctors can be taking care of the really sick patients who actually really need to be there, and the rest of the care team can take care of the chronic illness patients who, they're healthy, they're chugging along their normal day, but there's no intervention happening, it's only happening every 3 to 6 months, and so there's really not much headway being made. And so we feel like if we can touch them a lot more often during the year, behavior will change, medications can be changed without there being an issue with safety, and they ultimately will be healthier and not need to come as often.
Exactly.
Yeah, I just want to say that's really good, a very good point. That from the patient's point of view, I'd love to give you the information. Going in to give that information means taking off work, means, it's a big effort, right? And if all you need is the data, how can I give that to you, right?
Sure.
And I think you'll get more information.
And internally, we refer to that as allowing care teams to spend less time checking in, more time helping out. Like, more time doing the work you're supposed to be doing.
Right.
And actually getting accurate information, because I know I'm a diabetes educator, and I know some of my patients really are telling me the truth when they're saying, well, how's your blood sugar? Oh, it's good. It's good. Okay. And so their A1C is 9 when it comes back. And there's a lot of
We've been there
that.
before.
What I equate that to is the first day of one of my kids at high school, the principal said to a group of parents, let me just tell you the first day, kids lie. I'm going to tell you, diabetics lie. Because we don't want to tell you, we don't want to disappoint, right? Because we work hard at it, we just can't figure it out. How do we do this thing, right? And so we say, yeah, we do it.
Yeah, and the point that you made about the popcorn is just so poignant, because that happens in my practice so many times. I had a patient who was like, well, how'd you change your diet? Oh, I'm eating really healthy this summer.
Yeah.
I'm eating a ton of watermelon. And I'm like, oh dear. The watermelon is the highest sugar content of all the fruits possible. And she couldn't figure out why, her A1C was so high, and let's just take off the water, and then she did fine. But so it's amazing that, the perspective of the patient is they think they're doing something healthy, and really when you're diabetic, it may not be so healthy,
And the best we can do, honestly, is guess. We can just guess, and we base that upon the life that we've lived so far, right? If we didn't eat fruits and vegetables, we'll eat them now. The biggest thing I learned from my diabetic educator was that salad has carbs. I thought it was like zero, nothing, right?
That was a free food,
It was
right?
free, just nothing, right? And oh no, I have to count those too?
But now that we can keep an eye on you.
Oh, right. And now you can give me feedback, right?
Exactly. One of the things I'm curious about, Rusty, is, one of the things that we struggle with is this concept of sort of download to drawer time, right? That, it's great, we download the app, we have it for a couple of weeks, and then we stick it in the drawer and we don't, ever want to see it again. What kept you motivated to keep using it?
That's a very good question. Why did I continue?
Because most people, even with a chronic disease, aren't going to continue.
Well, because here's what happens, is that what I use the data for is a guide. I don't use it as an absolute. The doctor is my absolute, right? Because he's the guy that's gonna, save me, right? But I use the data as the guide to live, without, very similar to what we just said, I'm guessing. If I have an app that helps me count my carbs, that's accurate, well then I can dose insulin based upon real numbers and not guessing what that plate is. Because we have no other way of knowing, right? The other thing that I found out that I thought really was helpful during the study was that helped me get my A1C down, is I was able to look, we started reviewing the data, right? We started looking at what the data meant for me, right? How I lived it. And what I saw was that incremental changes that I was making was driving my A1C down. That A1C to me was like, I call it, it's a report card, right? Anything over a 7 is an F, right? Because that's what the doctor wants you to be, right? It's a 7, right? And I could never get there. But the incremental changes started to push that down. You know, and I had a really high A1C, right? And you know, and we just started down a path. And it was the small steps. You know, there's not one big fix for this. You know, if it's out there, I really haven't found it. I've tried, you know, all the diets and all that. The small steps. And then what I got from the study itself is that I have always given my data, my information, and I got nothing back. You know, I get an A1C, and I can say, eat better, you know, eat healthier. With this study, I could take a look at what the data was, and I could see what I was getting. They were giving me something back in return. And then I began to trust it. And the more I trusted it, the more I developed, you know, looked at other areas. You know.
Yeah, I think a key part of what I noticed in that program, and what I've seen elsewhere work well too, is when there's a care program where up front you had a team that you set established goals with them. Your goal was to get your A1C down below 7. The care team was on board with that goal. Everybody knew that was your goal, and they were there to help you do that, and that was established up front. And I think a lot of times folks are in programs that maybe don't have those clear established goals at the outset, where the teams can really work together. So I think that might be one thing. I actually pursued RCT on that sometime and see if like that actually helps.
Exactly, right.
So Drew, as you're listening to Christine and to Steve talk about sort of how they use the technology, how does that inform where you're taking Validic, the next step, or the new tools that you're coming up with?
Yeah, the feedback from patients and from clinical staff team members who are actually using the data on a regular basis is critical, because we learn what is hard about adopting patient-generated health data. And I was in a conversation earlier today, and somebody said it far better than me, so I'll just give a direct sort of quote from the conversation, which is that, you know, generally speaking, we are going to use tools that are sort of the lowest barrier to entry path, right? The lowest common denominator path. And the fact of the matter is that being healthy in this country, generally speaking, is kind of hard, right? It's kind of hard. It's hard to get exercise, like we're driving from our driveway to our parking ramp, and then sitting in our desk all day. And it's kind of hard to just be healthy. And so, you know, one of the things that we try to do at Validic is how do we reduce the friction around actually just using the patient-generated health data? How do we help patients collect the data in a way that's very simple and straightforward and they don't have to think about? How do we help the clinical staff members use the data and implement that in a way that's easily accessible in their workflows? They don't have to actually think about it. And it's a concept that I actually call invisible healthcare. And the reason I call it that is because technology, fundamentally, when it's designed properly, becomes invisible. So, like, how many people in the room have like a Amazon Echo or a Google Home device? Yeah, many of you. How many of you actually think about it on a regular basis? You don't think about it, right? You just use it. It's just there. It's like in your kitchen. You set a timer, or my 4.5-year-old tells it to play the Batman theme song, and he dances around, and it's just like a part. It's just like a part of the thing, and you don't even think about it, and that is the idea of technology becoming invisible. And how do we do that in healthcare is something we think a lot about at Validic, because right now, let me tell you, technology is not invisible. We notice it every day, and I think the designer Jared Sproul, who's a user experience guru, said that design, when it's done well, becomes invisible. It's only when it's not done well that we notice it, and we notice it in healthcare. So we try to, at Validic, try to think through how can we actually make this invisible.
So, Steve and Christine, I'm going to ask you guys to just wave. If you had a magic wand, Steve, now that you've got Drew sitting here, you know, if you can design, you know, as I know, you should have brought it with you.
Yeah.
But as an end user, what do you want? What would you want as an end user? What is important to you, sort of in the next iteration of design, that you would like to see to help you manage?
You know, that's a golden question. And
That's why we have a magic wand.
right, you really nailed that question. What I want to say is the study that I was part of, the reason why I stuck through that study is because I did, the last thing I had to do, actually, let me take a step back. I take my blood glucose every day. All diabetics do. You take them 4, 6, 8 times a day. What made that study easy was the last step. I just had to take a picture of my meter. That was easy. So to be part of that study was easy. So I want to have that easiness and that user ability with me at all times. So I wanted to, the next thing is I want to be able to integrate all of what I have in terms of my health into one map. All right. So for my diabetes, if I can look at my blood glucose, if I can integrate the pattern of it, but also if I can put in there what I ate, not just the carbs, but the what, right? So that it's 22 carbs and it's popcorn. So I can see what that popcorn did and how fast it rose. I mean, all that information helps drive my behavior. And so integrating all that together from a user point of view, from my point of view, right? That helps me. I'll make better decisions. I'll even make better decisions for my family because I'll know what to buy and what not to buy. So that's my magic wand, is integration.
Good. Christine, from a provider perspective, what would you like to see?
So I think at this point, some of the apps can be a little clunky, and so I would love to see blood pressure, blood sugar, weight, all getting integrated into one app and sent through Connected Health into Epic, all in
2
one.
weeks.
I know.
We're like really close.
I'm like this. So part of the struggle with the blood pressure products is that they all have their own apps. And so you have to go and you have to have the patient download their app. Sometimes their apps aren't that, they don't have 5 stars. They have like 1.5 stars. And so sometimes connectivity can become an issue, and it's not on the Connected Health side, it's on their app side. And so you're constantly trying to figure out where the connection disruption is. Is it Epic? Is it Connected Health? Is it Gateway? Is it the app itself? And so to make that one streamlined system, and then it would just make things so much easier. It would decrease frustration on the patient side as well, because they're taking their blood pressure and we're not getting it. So they're getting a phone call from the nurse saying, how come you're not taking your blood pressure anymore? You're like, well, I am. And so it's that disconnect that we've got to work on. Is we've got to keep them connected, because if you don't keep them connected, they're going to stop using it.
Yeah,
And
that's
that's the
visible.
frustration.
Yes.
Yeah, that's visual.
Yes.
Exactly. But otherwise, I think one of the other issues that we had in the practice, or an anxiety that we had, was who owns that information. And so to make it so it's not the doctor who owns it, it's not the nurse who owns it, it's the team who owns it, and that we made sure that the patient understood that if there was any kind of an emergency situation, they still had the protocol to call the clinic, that we weren't checking that data 24/7. There was no expectation that if there was a blood sugar or a blood pressure of 200 over 100, we're not going to see that right away. So if you get that, you call us. So it kind of took all the anxiety away from the doctor and the nurses with liability issues, and the patient with, I didn't get a phone call. How you saw that? How come I didn't get a phone call? So I think laying ground rules is really, really important as well. So everybody knows what the expectation is. So
I think, to your point, it's one one of the things that we struggle with as well, is that, you know, there are some apps that you're right, they're maybe 0.5 star and some are 5-star, but, you know, the challenge is that the patient doesn't know that, and nor should the patient know that, right? That the patient just knows that I'm being asked to use this by Revere Health Center, so therefore it's got to be, you know, XYZ Health Center that created this. And so, you know, for those of us on the back end trying to figure out how we're going to integrate all this technology, recognizing that some apps are good and some apps aren't, and how do you make that a frictionless experience for the patient, it's a challenge. But there is an app coming your way for those of you who work in partners, so, so we can integrate the data in one place. So,
That's great.
you come to partners, Steve, you can.
I will, you know what, from a patient's point of view, if products like that will move me there. I was just having a conversation about how mine doesn't do this.
Yeah.
Yeah.
You know, and that'll make me walk.
And by the way, Kelly, I'd be a terrible entrepreneur if I didn't mention that when Steve said he took a picture of his glucose monitor, that's actually a product that Validic has.
Oh, yeah, I'm
It's
sorry.
a patented technology. We actually just announced the patent today, but that uses the camera on the phone to read the data off of a medical device and digitize that and send it up to the cloud. So very easy to use, and it takes it validates the reading from the actual device when it's a non-connected legacy device.
Yeah, but you know what, it's really easy. You know, I mean, that's the key. And not even knowing that all that's behind it, right? So that's wonderful.
But that's how it should be, right?
That's the way it should be,
Exactly.
right? You know, just take a selfie of your.
A selfie. Just don't take
That's
a
what my
flying
kid.
cliff, right?
That's what my kid told me. She says, "Dad, you're taking a selfie of your monitor." Yeah.
Oh, hey, you know you're into this.
Yeah.
What I'd like to do is open it up to questions. We've kind of given you some ideas, what we're doing. Does anybody have questions about what's happening?
Thank you for your talk. Grace Cordovano, I'm a board certified patient advocate. I loved your story, Steve, and I love what you guys are doing collectively. What I'm not hearing, or perhaps I might have missed, or maybe you didn't have a chance to touch on, is how the caregivers can proactively use the data to see where a patient might need extra support or resources. For example, a lot of chronic illness or patients with diabetes would benefit proactively from a nutritionist as part of their care team, because it's overwhelming. It's a big life change. Instead of saying, oh, well, you know, there was too much sugar there, or the patient didn't know, we can't expect and assume everyone to know the nutritional content of everything. So do you have any comments on that? Do you use the data to see significant pitfalls or drops in a patient's health trajectory, where you could say, hey, you know, maybe they could have a nutritionist or a social worker, perhaps a trainer. How can we use something non-technological with the data to enhance care?
That's a very good question. So part of our diabetes care, we're actually not using the diabetes portion, we're only using the blood pressure portion at this point. But, you know, we're hoping to move forward and using the blood sugar monitors as well. But we have a care team for diabetes, and so it does include a nutritionist. And so just to let you know, like the way it works with our clinic right now is if we see trends of blood sugars going up or things like that, we engage the nutritionist, and there's also physical therapy and things like that we do engage. We have social workers on hand as well, like the ICMP program, which helps the older patients in our clinic, and so they get connected with all sorts of outside resources in the community.
Thank you.
Do you have, I'm just
So
curious as far as,
I'd like to address that
Yeah.
because it was actually my care team, and specifically my diabetic nutritionist, who looked at the increases in the evening. I mean, she goes over it with my endocrinologist, but she's the one that sees me on a monthly basis, and she gives guidance to my choices, right? And it's at that point that she looked at it, she could see it, because she talks to me all the time. So I think you're right. I think the important part is that the care teams are in the loop. And I say care teams, there's case managers, there's nutritionists, there are nurses, there's a team of people. So I use that word loosely. There might be a professional term for that, but from the patient side, I look at all of them as my teammates. Like, so I think that they are, as they're close to me, they're a good source for looking at the data.
I think that's a good point that both Steve and Christine bring up, because one of the things that we hear is technology is taking us farther away from the patient, right? I'm not interacting with the patient because all I'm doing is I'm just looking at data and I'm looking at numbers. And as we listen to Steve and Christina, it's actually improving their communication and it's improving their relationships with the patient. And I think that's an important message to convey, that, you know, used correctly, it really does enhance that aspect of patient care that those of us who are clinicians worry about, right? We worry that the patient's going to get lost in all this data, and we're not hearing the stories about how we're improving care, we're making things better, we're enhancing the communication.
Yeah, you know, and if I could just add on 2 quick things on here. One is Steve has a great story about how the data actually became the language for his clinic, for his physician, and him to communicate, rather than sort of a paternalistic, come on Steve, you need to eat healthier. Now there was data, and Steve said, well, what do you mean? Like, look at the data. This is what's happening. And I think that's
Yeah, you know, I look at it as doctors talk doctor and I talk patient, right? I mean, they do. You know, doctors they're scientists, right? They go by data. They don't go by how you feel. They're not educated that way. I go by how I feel every day because that's all I have to go by. I don't have the data, right? You know, and even if I have it, I don't understand it. So what we were able to do is change the conversation. It was a monologue. We moved it to a dialogue. We had an exchange of ideas. We use the data as our language, language about how I feel. I can tell you how I feel based upon what number it is, right? But I learned that. I didn't, you know, it didn't come with the disease, right?
The other point, thank you for that, Steve, is what I'll call rogue remote monitoring that's going on right now, where you know, there are physicians today in every health system across the United States who have remote monitoring deployed for their patients, and it's not going through the electronic health record, and it's not, I mean, this is happening because physicians genuinely care about the health of their patients, and this is genuinely an amazing way of getting more information about them in their daily lives. One quick story, I was talking to somebody who prescribed CGM data or CGM for his type 1 diabetic patients. What would happen is, there was no way to get that data into the electronic health record. By the way, there was a press release that Validic announced yesterday where we get CGM data. But regardless of that, so what he did, what he would do is he would ask his patients to add him as a friend in the CGM app, and then he would go home. And he would go home and he would log in on his personal computer into the CGM app website, like look at the data, pull up his work laptop with Epic, and he would review the data and then type in what was his notes about what was going on. And this is how he's managing his type 1 patients. Now, it's an incredibly dedicated physician, and I know it's not an N of 1. I know this happens in other health systems across the country. So this is something that. What's that?
Not ours, because we haven't integrated into the EHR.
That's right. That's right. Present company.
Yes.
You know, I was just going to say, you know, looking at the data is, from a patient's point of view, I think I've come to learn what that language is. And I was driving down the road the other day, and I was thinking kind of about how I look at my A1C and how in the past I really thought that was the most important thing, that I had to drive to get to that number. Although that's true, I still do that, right? I still do that. But now I have a way. And my view of that, driving down the street, was I looked at my rearview mirror and I said, that's my A1C. And that's how big the picture is to me. I'm looking behind me. I've already been there. That's not gonna change. That's 7.8 or 8.5, it's too late. but that windshield is big. And I can change for every step that I move forward. And I can see the car over there, and I can see the roadblocks over there, and I can see the challenges. And I think, for me, capturing the data and communicating that to my physician is so important. Because of that view, I can make the changes I need to make.
Yeah, no, I think that's a very good analogy. Any other questions?
Hi, is there any way you could just speak a little bit more about how the blood pressure data is being collected and sent back? Like, is it with an internet-connected device? Is it with a legacy device, and they're self-reporting it through an app?
So what we're doing is we are using the Omron app. So it's an Omron blood pressure cuff, home blood pressure cuff. What happens is when they're randomized into the intervention part of the study, is they come and see me for a visit, and I get them all, signed up into the study consent forms, and then I help them put the app on their phone, and then we take a blood pressure in the office and compare it to a blood pressure, on the office equipment to make sure they're, comparable. And then the blood pressure cuff gets paired to the app, and within the app it goes through Patient Gateway into Epic. So it's a long, confusing little thingy, but it actually works pretty good. So we have to have a Patient Gateway account, and so the process for our patients, some of our patients are very technologically savvy, others are not. And so that process can take from 5 minutes to 50 minutes, depending on where they are in that spectrum. But once they have it all connected and everything's paired, they have to do nothing else. They just take their blood pressure and that's it. It just goes directly in there. So there's no, pressing a button or making sure the app is on. It just goes directly into there, and then we see it in Epic through the Connected Health little bar.
Yeah, so just to give you a little, so my team is the one that developed the PGHD Connect platform. So within the partners ecosystem, all providers have access to receive data for blood pressure, activity, weight, and glucose right within the Epic platform. So the provider can invite the patient to share their data. Once the device is paired, the information goes through the cloud and then comes into Epic via a sidebar report. So providers, while they're in their patient's record, can just click on a link, the sidebar report pops up, and they can see all of the readings that the patient has been taking at home. And so that's up and available right now for anybody that's a partners provider. Within a couple of weeks, what we're doing is we're expanding upon that with our mobile application. So as Drew talked about earlier, that will give us access to Vital Snap. So for devices that are not Bluetooth enabled, we will be able to take advantage of that OCR recognition, snap a picture, and then send that information up. And all of it, for us, will reside within the Epic platform so that providers can see it in their day-to-day workflow. That was one of the things that was important for us, is that we don't want to create a separate system that people have to go to. It really needs to fit within your existing workflow. The other piece too is that we wanted to make sure that providers had control over what they were receiving. So in our particular, the PGHD Connect platform, the provider has to invite the patient to share. So it's not just the patient deciding, oh, I've got a new Fitbit tracker I want to send you, everything I've been doing. It needs to be specific to what that provider is treating that patient for.
And I believe we'll also get the Omron BLE Bluetooth
Yes, exactly.
as part of that as well, right?
Mhm.
So that's
I'm sorry.
skip the app.
That'll be good.
I'm sorry, question, yes.
Is any of the device or any of the data that is going directly into the EHR, like in your app that's going to be released in about 2 weeks or whatever, for partners, is any of it self-reported, like patient takes their own weight and then puts it in, or is it definitely from a device that's being transmitted to the information?
So right now, it's all from the device. That was one of the things that we wanted to make sure is that we could pull the information in from the device, because Not that I'm not trusting Steve, but we've known patients that have, they take their blood sugar, it comes out as, 257, and they go, oh, I don't like that. So, in the past, we used to have patients come in with, their lists and, oh, I'm always, 98. So this way it comes in through the device. And I think we are at the 1:30 mark. So thank you all very much. We appreciate it.